be in the same sessions as him, and he would always be one of the first people up at the microphone to ask questions or make a comment. And he was just brilliant at doing that. I mean, it's something that I was just talking to a friend of mine about, how you could hear one of the worst presentations in the world where people would say something that was absolutely wrong. And I would just be, I had my head hung low, thinking, God, it's embarrassing to listen to this. I don't know what to say. If I got up there, I might say something really stupid. And Dennis would get up there and make a comment that would be able to clarify for the audience what they need to know about that, but without ever insulting the person who was speaking. And if he disagreed with you, he would talk to you about a way in such an incredibly respectful way. Dennis just had a gift like that. So it's a great loss. Now moving on to my talk. I have no disclosures. Today I'm going to talk about the epidemiology of colorectal cancer, or CRC. I'm going to talk about some of the recommended average risk screening tests and get into the question of which test is best. And since this is VA Research Day, I'm going to spend a bit of time talking about the CONFIRM study, which is a study that I am co-leading with Doug Robertson from the White River Junction VA. Now, when you think about screening for a disease, you want to do it when there's a significant disease burden, when there's a detectable preclinical phase, when screening tests are shown to be accurate and are acceptable to patients, and the screening tests need to be affordable and available. And also you need the treatment for that condition to be more effective when you apply it before patients are symptomatic. So let's think about how that applies to colorectal cancer. Colorectal cancer is the second leading cause of cancer death in America today. Second only to lung cancer, and since Dr. Keith is here, I'll do a shout out to lung cancer. We have almost 150,000 colon cancers expected this year, with about 53,000 deaths. Now, we've been hearing lots of big numbers, especially with the pandemic. These numbers may not sound so big, but they are huge numbers. Just, makes you impressed. It makes it all that much more impressive how big the numbers are with the pandemic. But since we see all these numbers, I think it helps to kind of put faces to these numbers. And the largest stadium I could find was the Bristol Motor Speedway. And the Bristol Motor Speedway seats about 140,000 people, which is less than what you get at in colon cancer incidence. So that's a lot of people every year getting colon cancer. Imagine every one of those people coming down with colon cancer in 1 year. Now, 53,000 deaths is actually more people than fit in T-Mobile Park, which is where the Mariners attempt to play baseball. I mean, I don't mean to make light of colon cancer mortality, but this whole stadium, if it's full, and the stadium was full earlier this week, my wife and kids were all there on their last game, but it's emptied by the deaths. It's tragic every year, and these deaths are preventable. And so is there an identifiable and treatable preclinical phase? Well, on the left-hand side of the slide, you see the 3 common pathways for carcinogenesis in colon polyps. And note that this slide is from Dennis Ahnen. Dennis taught us so much about the pathogenesis of colorectal cancer. This is from his Emily Couric lecture, the sister of Katie Couric, that he gave a few years back. So we've learned a lot about the genetics of colon cancer through people like Dennis Ahnen. And we know that these polyps can be identified through colonoscopy and removed. And by removing them, we can cure colon cancer, because sometimes these polyps are cancerous, or prevent them from ever becoming a cancer. Now, so we have screening tests, but how acceptable are they to patients? Well, what you see here is data from the National Health Interview Study showing that cervical cancer screening rates are well above 80% and have been for many years. Breast cancer screening rates above 70%. Colorectal cancer screening rates are lower. They've been climbing. We want to get over 80%, but clearly we have work to do in this regard. So let's talk about the different screening test options. The U.S. Multi-Society Task Force is a group made up of individuals representing the 3 major GI societies. I'm one of the representatives, and actually your own Swati Patel is a representative as well on this task force. And we made the recommendations for the screening test shown today on this slide. The Tier 1 test, or colonoscopy every 10 years, or fecal immunochemical tests every year. Tier 2, CT colonography, FIT fecal DNA, or flexible sigmoidoscopy, and Tier 3, capsule colonoscopy. We did not recommend the blood-based test for methylated septin-9. Not on this list is the digital rectal exam. This used to be recommended as a way to screen for colorectal cancer. Apparently, this rugby player didn't get the memo. He was suspended for trying to help his opponent prevent him from dying from rectal cancer. Only about 5 to 10% of cancers are within reach of the examining finger. So let's talk about those tier 1 tests, colonoscopy and annual fecal immunochemical tests. So colonoscopy, I love colonoscopy. That might seem kind of weird. I'm a gastroenterologist. I love performing colonoscopy. But we do not have randomized controlled trial evidence supporting colonoscopy for reducing colon cancer mortality. We have cohort studies like the 4 shown on this slide. The first one is from the nurses and physician health studies, showing that overall the risk of death is 0.32 in individuals who've had colonoscopy. That means a 68% reduction in cancer mortality, and you see the confidence interval below that. So 68% reduction in cancer mortality when you look at people who had colonoscopy compared to people who did not have colonoscopy. Nancy Baxter showed about a 60% reduction in her study. Chike Dominitz from Kaiser shows a 67% reduction, and highlighting VA research again, Charles Kahi from Indianapolis and colleagues looked at US veterans and showed a 61% reduction in cancer mortality. So multiple studies showing that colonoscopy is associated with reduced mortality. On the right-hand side of the slide, you see data showing that the mortality reduction is better for left side of the colon than right side of the colon. And we can talk about that later if people are interested, but that gets into issues of the biology of colon cancer as well as technical issues with colonoscopy. Now, this study came out just in the last year from Poland, showing that if you have a negative colonoscopy, your chance of dying of colon cancer over the next as long as 17 years is very, very low. So having a negative colonoscopy is risk stratifying and shows that that's associated with a very low risk of dying of colon cancer. But also shown on this slide is it depends on who did your colonoscopy. In the black squares are colonoscopies done by the low quality colonoscopy group versus the open squares are the high quality colonoscopy group. So if the doctors are very good at identifying polyps and you have no polyps, that's a very strong association with protection from future colon cancer death. But we do know that a lot of people who have a colonoscopy that's negative do subsequently get colon cancer. And this slide shows the data from 4 different cohort studies. And you see that somewhere between 3 and 9% of people who have had a colonoscopy, between 3 and 9% of people who have a diagnosis of colon cancer actually had a colonoscopy in the preceding 3 years that did not detect that cancer. So colonoscopy is not a guarantee that you're not going to get colorectal cancer. And when we try to understand why colonoscopy does not perform as well as we'd like, we'd love for colonoscopy to be 100% effective at reducing future colon cancer mortality. There's a number of factors that come into play. It could be that there's biological issues where there was no colon cancer and a new cancer grew quite rapidly over those 3 years. But we also know that there's some quality issues among the doctors performing colonoscopy. And here we see data from another VA researcher, Dr. Asma Shaukat, currently at New York, but she's at the Minneapolis VA when she did this. She looked at 51 non-VA gastroenterologists, I'll mention, and they determined how long they spend pulling the scope out. We examine the colon on withdrawal. You put the scope into where the appendix is, called the cecum, and you withdraw the scope and look for polyps. And when you measure how long they spent looking in people who had no polyps, you can come up with an average withdrawal time. So every one of the 51 physicians had an average annual withdrawal time. And what you see here is that when the withdrawal time was about 8 to 9 minutes or more, the risk of interval cancer, the y-axis, the risk of interval cancer was fairly low. But as that withdrawal time got quicker, the risk increased significantly. So we want doctors to do a careful exam, to not pull the scope out too fast. I did a study once where we timed people with stopwatches, and we found a doctor who spent on average 2 minutes withdrawing the scope. Now, some people call that a lawnmower colonoscopy, like they're trying to start their lawnmower by pulling the scope out of the colon. So obviously, we don't want to encourage that kind of behavior. And there's a really nice study from Kaiser of Northern California showing that there's a strong association between the detection of polyps, the proportion of patients who have polyps detected, and the risk of patients dying of colon cancer. So what you see on this slide is a summary of data from over 100 gastroenterologists in the Kaiser system. They divided them into quintiles. The highest quintile are people who have a high adenoma detection rate, or ADR. That is the proportion of screening colonoscopies in which 1 or more adenomas are found. And you see that it ranges from a high of around 53% to a low of 7.5%. Our guidelines recommend you should detect adenomas at least 25% of men and women, 30% in men, 20% in women. So if you look at this slide, you see quintile 3 in the middle has an adenoma detection rate range of 24 to 28%, which is right around what that benchmark is. And note that the risk of cancer, the hazard ratio, falls as that adenoma detection rate rises. In fact, every 1% increase in adenoma detection rate is associated with a 5% decrease in cancer mortality and a 3% decrease in cancer incidence. So we want high quality endoscopists. We want to make sure everybody has a high adenoma detection rate. Now, I don't know if anybody can see the polyps in the colon on this slide. I know some people might not have good lighting. The pictures are kind of small, but the computer could see them. And with artificial intelligence, we can highlight those polyps. I'll give you a moment to just take a look. You can see there's a tiny polyp in the center of the image on the top left, and the yellow dot marks where that is. Other systems draw a blue box around it. So these systems are now commercially available. One was just FDA approved this year, and people are employing these systems. I think it's still a little early in the process to understand when we should be using these systems, but it's very promising technology. But finding a polyp isn't good enough. We also need to remove that polyp. We need to remove it completely to prevent it from becoming a colon cancer. I mean, identifying polyps does a couple of things. It allows you to risk stratify people. Those people who don't have polyps are at very low risk, as I talked about earlier when it's a negative colonoscopy. And those who have polyps, we bring back for more frequent surveillance to try to catch polyps before they become cancer. But it also gives us an opportunity to remove those polyps and prevent them from ever becoming a cancer. And what you see on this slide is data from yet another VA researcher, Heiko Pohl from the White River Junction VA in Vermont. This is a landmark study, beautiful, elegant study, where they biopsied the polypectomy site after the doctor felt they had removed the complete polyp. And they found that there was residual neoplasia present about 10% of the time. But it varied by doctor. What you see on this slide is 5 different endoscopists. The one on the far left has a risk of incomplete resection around 7%, and the one on the far right was around 23%. And they have a recent paper showing that this is actually associated with recurrent colon polyps on subsequent exams. So we need to do a better job of completely removing polyps. Now, one of the other problems we have with colonoscopy is the social aspects of it. People, it's not an attractive procedure to undergo. People don't like the idea of having an invasive procedure, having something put into their rectum and colon. And we have to be honest with ourselves. It is an invasive procedure with risks. When you look at the risk of complications, the risk of bleeding from these large population-based studies is 1 in 385, and the risk of perforation is 1 in 2,000. So when we compare it to other screening tests we do, like mammography or lung cancer screening with CTs, this is an invasive procedure that has a high risk of significant complications, but it also has significant benefits. So I don't want to get you wrong. I'm a huge fan of screening colonoscopy. And we've developed ways to manage some of these complications. This study from Korea shows that about 80% of the perforations can be managed endoscopically. So it used to mean surgery for everybody, but now it doesn't mean that. And there was no mortality from perforation in this very large study. Now let's move on, to fecal occult blood testing. So fecal occult blood testing has been around for a long time. We used to use the guaiac-based test as shown on this slide, where samples of stool are taken from 3 consecutive bowel movements. And with this kind of screening, there are multiple studies that have shown a significant reduction in colon cancer mortality. The Minnesota trial is the only US-based study on the list here, obviously. And they did annual screening, biannual screening, which is every 2 years, or control in 46,000 people. And annual screening was associated with a 33% reduction in cancer mortality. Now, I told you that colonoscopy was associated with a 60 to 70% reduction in cancer mortality on the earlier slide. That's from cohort studies. Everybody in those studies who was in the colonoscopy group had a colonoscopy. Now, this is from a randomized controlled trial. Not everybody who gets randomized to occult blood testing actually had occult blood testing. So this is getting more at the effectiveness than the efficacy of screening. And so it's not fair to compare these head to head. And if you go out 30 years, Ozma Shauka, again, the same investigator I mentioned earlier, published this in the New England Journal a few years back, showing that even though screening was only done in the first 12 years, and it wasn't even the entire 12 years, that 33% reduction in mortality persisted out to 30 years of follow-up. Moreover, there was a 20% reduction in cancer incidence with annual screening, 17% reduction in cancer incidence with biennial screening. I've heard it said that colonoscopy is a cancer prevention test and occult blood testing is a cancer detection test. And there's some truth to that, but there also is some cancer prevention, as evidenced by this slide, with occult blood testing, because when the test is positive, if people get a colonoscopy, which is what should happen, then you have an opportunity to remove polyps and prevent future cancer. There's been improvements on the guaiac fecal cord blood test, the fecal immunochemical test as shown on this slide. We see a collection device on the left. And it's, instead of those 3 samples I talked about earlier, only 1 sample is typically used, and there's automated processes. So labs like this, it's a very efficient way to process the specimens so you can get a quantitative value of how much human hemoglobin is in the stool. And if it's over a certain threshold, you call it a positive test. There's multiple studies as shown on this slide, randomized controlled trials showing that people are more likely to participate in screening if they have the fecal immunochemical test or FIT than the guaiac test. As I said, it's easier to use. So about 9% increase in screening. And if you look at how good the test is at detecting colon cancer, we find from these pooled studies, this meta-analysis, that the pooled sensitivity for colon cancer is around 79%. So about 4 out of 5 colon cancers will be detected, and the specificity is 94%, so about 6% false positive rate. Of course, we'd love for that sensitivity to be 100%. It's not. It does, as the test is done every year, you do have multiple opportunities to catch a colon cancer, to detect it, and colon cancers tend to grow slowly, and it can detect large adenomas. So theoretically, a program of annual screening will pick up more cancers than just 1 round of screening, and I'll come back to that point a little later. In Kaiser, they've reported on the results from several rounds of screening. And if you look at the column labeled 1, that's in the first round of screening. They sent out 670,000 FIT kits. Participation was around 48%. 5% tested positive. And on colonoscopy, they found advanced adenomas, which are large or worrisome polyps based on their histology, in 14% of people, and cancer at 3.5%. And they estimate the sensitivity at 85%. They don't know the true sensitivity because they didn't do colonoscopy on everyone. In subsequent rounds, looking at people who participated in the first round, you see that participation rates are much higher. The cancer detection rates are lower, likely due to detection of prevalent disease in the first round of screening. And now you're picking up some of the cases that were missed or new cancers that developed. But as I said, when you have a positive test, you need to do a colonoscopy. And this is where we have a challenge. I'll talk more about this tomorrow. When you look at mammography, women have very high rates of diagnostic evaluation for an abnormal mammography. It's over 90%. Cervical cancer screening, on the other hand, at the bottom of this graph, is much lower, below 50%. And colon cancer screening, the diagnostic colonoscopy evaluation is in the middle, and it tends to vary quite a bit. Programs like Kaiser have high rates of screening, of diagnostic evaluation, around 80%. The VA typically has been more around 50%, as we've seen in county hospitals like Parkland in Dallas. Now let's move on to the tier 2 tests. We have CT colonography every 5 years, the FIT DNA test every 3 years. That's the test you commonly have heard of as Cologuard, and flexible sigmoidoscopy every 5 to 10 years. I love the idea of CT colonography. It is phenomenal technology. They get these beautiful images. This is from Perry Pickard's landmark paper in 2003. In the lower right-hand corner, you see the endoscopic view of a colon polyp and the appendiceal orifice designated by the arrow on the left. And if you look right above it, you see the CTC 3D reconstruction of that. It's remarkable. The technology is phenomenal. I'm sure this is the best picture they had, which is why it's in the journal, and they don't all look like this. But still, you got to give them credit. They're taking 2D images and making these beautiful pictures. So how well does it work? Well, I don't have any studies showing you randomized controlled trial evidence that it reduces cancer mortality, nor do I have any studies on its cancer incidence impact, or cohort studies like I showed you for colonoscopy. We have our studies that compare colonoscopy to CTC. If you do CTC, how many lesions are detected that were also seen by colonoscopy, and so on and so forth. What you see here is that the sensitivity for polyps a centimeter or larger, what we call large polyps, is 90%. And the specificity is 86%, so 14% false positive rate. The question is, when do you send a patient for a colonoscopy? Is it only if they have a polyp a centimeter or larger, or do you do it when they have smaller polyps, like 6 millimeter polyps, or do you do it when you see any polyp with 1 millimeter or 2 millimeters in size? This is a bit of a challenge because we find polyps of any size in about half of veterans. And so if any polyp would require a colonoscopy, we'd be doing colonoscopy on 50% of the people who have CTC. The radiologists and other advocates have recommended using 6 millimeters as the cutoff. So you see the sensitivity at 6 millimeters is 65%. This is in the hands of high quality radiologists. This was not open to the general public to do this, or general radiologists. This was radiologists who passed specific criteria to be part of this study. And this study was done before the era of sessile serrated polyps. Dennis Ahnen, again, was a leader in educating us about sessile serrated polyps. And what you see here is a polyp that looks very different from that polyp I showed you on that very early slide. I showed you what we call a pedunculated polyp, like a giant mushroom. This is very flat. Endoscopically, we see this rim of debris, that yellow stuff around the polyp where the arrows are. And note that the dashed arrow on the right is pointing to a blood vessel. Note that that blood vessel seems to abruptly get cut off at the left-hand edge of the vessel where the polyp starts. So endoscopically, we're being trained, and 30 years ago, we weren't looking for these. Now we're looking for them based on work of a number of people like Dennis Ahnen. And here's other images showing how subtle these are, and could CTC detect these lesions? Well, if you look at the data from the Dutch, we see that it doesn't. When you look at a more modern analysis before that Ahnen trial I showed a few slides ago, we see that colonoscopy is detecting fourfold or somewhere in that neighborhood more lesions of the sessile serrated lesion type than what CTC can pick up. Let's move on to the FIT DNA test, commonly known as the Colorectal test. So this is, again, phenomenal technology. The idea is that our colon is constantly shedding cells. These cells have either normal DNA or abnormal DNA. If it's abnormal DNA, that's a marker of cancer. Detecting that abnormal DNA is a way of detecting a colon cancer or worrisome polyp before it gets to be too late. Great idea. We're looking for a needle in a haystack. And companies have been working on trying to find that needle, and this one test is on the market now and is available. So what happens is you order the test, they send a box to the patient's home, the patient provides a stool sample. It's not just stabbing the stool with a stick like I described earlier for the FIT test, or like I showed you. This requires a larger sample. The manufacturer used to have baby Ruth bars, the mini baby Ruth bars, as an example of what you need to send in. And then they analyze it. And if you put in too much stool, the buffer won't work and it'll degrade it won't work in the test. If you do too little, it might not work either. What they're looking for are aberrant methylation of MBP3 and NDRG4 promoter regions, the mutant KRAS, but they're also looking for blood. The FIT test is part of this. And it's a complicated algorithm of how they analyze this to determine if the test is positive or negative. And they don't tell you what's abnormal in the test. It's just positive or negative, normal, abnormal. And when you compare the FIT DNA test to FIT, you see that it is more sensitive for detecting cancer, 92% versus 74%. It's also better at picking up precancers, those worrisome polyps, 42% versus 24%. And better at picking up the sessile serrated lesions I told you about a few minutes ago. This comes at the expense of specificity, more false positives. Now, this is a head-to-head comparison of the two tests compared to colonoscopy as the gold standard. At one point in time, the FIT DNA test is recommended every 3 years by the manufacturer. The test costs between $500 and $600. The FIT test is recommended annually at a cost of about $20. So if you were to do this test, the FIT every year for 10 years versus Cologuard every 3 years for 9 years, which one would be better? I don't know. Nobody knows. If you did it for just 3 years, which would be better? The sensitivity of FIT would get to be better than 74%, but the specificity would fall below the 95%. So what's better? We don't really know. People try to model this because we lack scientific data. But one of the other things to worry about with this test and some others like CTC is, what do you do when you have discordant results? What I mean by that is the FIT DNA test is abnormal and you do a colonoscopy, you don't find anything. What does that mean? Does that mean that it was a false positive test? Does it mean that the colonoscopy was a false negative colonoscopy? Does it mean that the patient is at risk for developing colon cancer because they've got these DNA changes, but the polyp hasn't grown yet, the cancer hasn't developed yet, you better keep a closer eye on this person? Or does it mean that they have something else going on, like lung cancer, or esophageal cancer, gastric cancer, pancreatic cancer, because these mutations are not unique to colon cancer? So they published this study showing that if you look at the concordant cases, which are those where the FIT DNA was negative and the colonoscopy was negative compared to the discordant, there were 2.5% of the people with discordant findings had an aerodigestive cancer in the ensuing 5 years versus 1.1% of those were concordant. Statistically, this was not significant. If it was 6 cancers in the discordant group, it would have been statistically significant. It was 1 patient away from being significant. So the authors of this paper concluded that if you have a negative colonoscopy, you don't need to do anything else. Do your usual follow-up, 10-year follow-up. And based on the data, if you say statistical significance is 0.05, and I'm going to take that as the gospel, then that's the right thing to do. Doug Robertson, my co-chair from the Confirm study, and I wrote this editorial where we said it's kind of it depends on if you're a glass half empty, glass half full person. And we'd like to see more data. I'm not trying to knock this test that there's something wrong with it because it detects aorodigestive cancer or might detect aorodigestive cancers. It's just something we have to think about as a healthcare system. What do we do with these patients? And I'm doing a study now funded by the GI societies looking at what people actually do. I'm curious because anecdotally, I hear people are nervous and they do more. They do a CT scan or they do another colonoscopy, they do an EGD, or who knows, they might do a chest x-ray to look for lung cancer. So we're going to try to look at some data to look at that issue. If you look at decision models, we see that we want a cost-effective screening program. And on the x-axis is years of life saved. So you want to be on the far right side of that graph. And if you look at the y-axis, that's the cost. So you want to be at the bottom of the y-axis. So what's close to the bottom? Well, FIT every 1 or 2 years is the closest to the lower right-hand corner. FIT DNA every 3 years doesn't add any more years of life, but it does add cost in this model. And models have assumptions and limitations. And this is based on 100% adherence. Maybe it's easier to do a test every 3 years than it is every 1 year, and that makes sense. But it depends on how involved the 2 tests are. They're not the same. If you decrease adherence to 50% consistent and 27% intermittent, we now see clustering of this. So adherence is really an important factor that I'm going to talk more about tomorrow. Colon cancer screening is only going to work if people actually do it. And so the relative effectiveness of different tests depends to a large extent on the relative adherence. Now let's move on to sigmoidoscopy. Some people say sigmoidoscopy is like doing mammography on one breast. There's some truth to that, but there are also other differences. I mean, you are only examining half the colon, but if you find polyps in the left colon, you do proceed to do full colonoscopy if they're precancerous polyps. And sigmoidoscopy is easier on the patient, easier on the provider, it's faster. It's not very commonly performed in the US for a variety of reasons, including reimbursement challenges, but no sedation is required. We have multiple large, huge randomized trials showing that sigmoidoscopy reduces colon cancer mortality. The first study is from the UK, and note the P-Y is person years of follow-up. So in the intervention group, they have 620,000 person years of follow-up, and in the control group, it's over 1 million person years of follow-up. It was something like 150,000 people in that study. The last row is the US study from Rocky Schoen and colleagues at PLCO. And there they have 872,000 person years of follow-up in each group. So huge, huge studies. And there's overall a 27% reduction in cancer mortality with sigmoidoscopy. Now in tier 3, we have colon capsule. Again, I love this technology. It's really quite cool. You have a little capsule that patients swallow. The problem is anybody who's ever done colonoscopy knows the colon is not clean. You can't see anything unless you wash the stool out of it. Even after patients drink the bowel preparations, we often do a lot of washing. So in order for this camera to get good images, it has to be incredibly clean. So the bowel preparation is more aggressive for this. And one of the biggest complaints about colonoscopy is the bowel prep. So this requires a more aggressive bowel prep, and there's other technical challenges I won't labor right now, but batteries can fail and it may not, it sleeps for a little while and starts taking pictures, but it can get some phenomenal pictures. How well does it do compared to colonoscopy? In this study of nearly 900 people who had this study and then colonoscopy, we see that it detects about 92% of large polyps and 88% of the 6 millimeter and larger polyps. So similar, maybe a little better than what I showed you for CT colonography. It also seems to do a little better for cell-ulcerated polyp detection. And the specificity is 95% for large polyps, 82% for smaller polyps. So that's a bit of a concern, an 18% false positive rate. So we'd have patients take this bowel prep, do this procedure, then you have to download the images. It's unlikely you're going to be doing colonoscopy on those people that day. I mean, maybe it's possible, but it's going to be challenging. So in reality, they're probably going to have to do another bowel prep after these images are read. Now let's move on to the last test, the Septin9 test. Because it's not recommended, I'm not going to spend a lot of time on this, but I'll just tell you one of the reasons why it's not recommended is it doesn't work that well. I mean, the sensitivity is 68%, specificity is 80%, lots of false positives. What's great about it is it's so easy. It's a blood draw. That's what's scary about it, because it's so easy that people may do it even though it's not a good test. And you guys know the story of PSA and all the challenges of PSA. I think we would have similar kinds of challenges with this test. What do you do with the results? So I think we meet the criteria for screening for colon cancer, but we haven't answered the question of which test is best. The US Preventive Services Task Force said we have a lot of test options and we don't have head-to-head studies to tell us which one is best. This is what they said in 2016. They have new recommendations that came out this year. I didn't see a similar type of statement then, because I think there are some head-to-head studies that are starting to appear, like this one here that just came out in press this year. So remember I said with Cologuard versus FIT, I want to see several rounds of screening to compare this programmatically. Well, this has been done with FlexSig, as shown here, one FlexSig shown in orange versus 3 rounds of FIT shown in blue. And this is based on, people may not be fully adherent. So colon cancer detection was 0.27% with FlexSig versus 0.49% with FIT. So FIT actually picked up more colon cancers, 3 rounds of FIT, more colon cancers than sigmoidoscopy. Also more advanced adenomas. Not answering the question which one's best at reducing cancer mortality, but it's giving us a clue that FIT can, with repeated screening, do better than than sigmoidoscopy. We have 4 randomized trials going on right now comparing colonoscopy to FIT in the confirmed study, comparing colonoscopy to no screening in the SCRISO and Nordic studies. And the colon prep study from Spain is similar to the confirmed study. Let me show you some data from the Spanish study. So what they did was they randomized 57,000 people to colonoscopy or FIT. Note that, I don't know if it's cut off on your screen, but on my screen it is. FIT had 33 colon cancers. Colonoscopy found 30 colon cancers in the first round of screening. So I told you FIT has a sensitivity of 80%, roughly 79%. And that's compared to colonoscopy, which is the gold standard, assumed to be 100%. So how can an 80% sensitivity test detect more cancers than a 100% sensitivity test? It doesn't make sense until you look at adherence or participation. More people are willing in Spain to get a FIT and follow up colonoscopy than were willing to get the colonoscopy in the first place, about 10% more. And FIT's going to be offered every 2 years in this study for 10-year follow-up. So it's possible that FIT will detect many more colon cancers. Now, colonoscopy does detect more polyps. They found about twice as many advanced polyps, and they would presumably remove those polyps and may prevent cancers. So I don't know how this study is going to end up, but I wouldn't be surprised if the two look fairly equal because of the participation difference. Now, because we don't have the studies we want, the US Preventive Services Task Force commissioned some decision models. These are really complicated. I'll go through these a little quickly. This model was looking at, should we start at 45 versus 50? And that's a whole topic in and of itself. And you have Dr. Patel on your faculty who could lecture about it far better than I ever could. She wrote the guidelines on this, by the way. So let's focus on the starting at age 45, which is the current recommendation. We should screen people age 45 to 75. And let's get rid of some of the tests that we're not going to focus on today, like the guaiac FOBT or the stool DNA every year. So what you see here is the life years gained per 1,000 individuals screened. Colonoscopy does the best with 337 life years gained per 1,000 people screened. FIT comes in second at 318. Stool DNA third at 303, and sigmoidoscopy brings up the rear, no pun intended, at 286. If you look at the number of cancers averted, we have, again, colonoscopy in the lead, 61 cancers averted, cancer cases averted, so it's preventing colon cancers. FlexSig now comes in second at 51, FIT every year, third at 50, and then stool DNA at 47. If you look at deaths averted, now the numbers get closer together, 28 with colonoscopy, and just the other tests are just a few patients fine. Now, if you're that patient who died, that's a big deal, right? So, how do we value these together? And then complications. Now here's where colonoscopy takes a hit. Colonoscopy has 16 complications per 1,000 individuals versus 10 to 11 for the other tests. Another way of looking at which test is best is if you have a limited budget. If you have $1 million to spend per year, and you're looking down 2 years, down the road, just over 2 years. You could spend $1 million screening 2,747 people with colonoscopy. You would obviously do 2,747 colonoscopies. You would prevent 13 cases, 6 colon cancer deaths, and gain 68 life years. But if you do FIT, you can screen 21,000 people. You'll do 60% as many colonoscopies, 1,500. You'll prevent 2.4 times as many cancer cases. You'll prevent 4 times as many deaths, and you'll gain 3.8 times as many life years. So if money matters, FIT seems to be a better way to spend your money. And it's a debate as to whether or not you should worry about how much it costs, because it may be better to spend more money and take care, you do colonoscopy for everybody. We don't know. Well, Sid Winter, the gentleman I showed you from one of the first slides, famously said the best test is the one that gets done and done well. And I agree with that statement. Now, how patients adhere to screening depends to some extent on how it's offered. If you just offer somebody FOBT in San Francisco in community clinics, as my boss, John Anadomi, did, a former boss, he had 67% of patients completed a fecal blood test. And when they offered colonoscopy, 38% completed a colonoscopy. If you gave people a choice, you see that 31% did a colonoscopy and 38% did an FOBT. So you could offer people choice, or you could just offer them one test, and you see what results you get. It was interesting that there were racial differences in the choice of tests. Here you see on the left-hand side, among African Americans, 20% chose colonoscopy and 34% chose FOBT. And if you look at whites, 52% chose colonoscopy and 18% chose FOBT. Latinos and Asians fell between those two extremes. Now, this study from Poland is just impressed now, showing a different way of offering screening. You could say to a patient, I'm offering colonoscopy. That's end of the story. I'm just going to offer you colonoscopy, take it or leave it. And they get 17.5% participation. Or you could offer colonoscopy, and if they don't participate, then you say, okay, you didn't want a colonoscopy, I'm going to send you a FIT kit. And now you get up to 26% participation. Or you can give people a choice between colonoscopy and fecal blood testing or fecal immunochemical testing and get about the same 26.5%. So many people advocate for sequential testing or choice as the way to go, and not giving patients just one screening option, because you get lower rates of participation. So now let me close by saying a few words about the CONFIRM study. So CONFIRM is funded by the VA Cooperative Studies Program. It's the largest intervention study the VA has ever undertaken. And it wouldn't be possible without Dennis Ahnen. Here you see Dennis at our last planning meeting. We had 4 planning meetings for this study. Dennis was involved in all of them. Next to Dennis is David Lieberman, who you may recall spoke at your prior Dennis Ahnen lectureship. And then you see me in the back. At the far right of the screen is Doug Robertson. He's the co-chair of the study. And between us is Jim Allison, who's a leader in FIT screening. And here is our first kickoff meeting in 2012 in Albuquerque. And you see Dennis highlighted there in the front, Dave Lieberman next to him. And here's Dennis again in our 2013 meeting. Camera technology got better, obviously. You can see the improvement in technology over the years of the study. Dennis is just such a key member of this study. We wrote our methods paper, and honestly, it was my job to write the methods paper, and I had writer's block. Dennis was like, how can I help you? And Dennis just worked on it and did so much. I cannot thank him enough. He probably should be first author on this paper. Such a loss. So here's what CONFIRM is. CONFIRM is a randomized study of screening colonoscopy versus annual FIT screening. We have 50,126 veterans from 46 medical centers, including Denver. You guys are one of our highest recruiting sites, actually. You see we have sites from Honolulu, Hawaii, to San Juan, Puerto Rico, to Manchester, New Hampshire, and Seattle, and almost everywhere in between. We started recruiting in 2012. Our last recruitment was December 1st, 2017. Now, I'm talking about people's preferences for colon cancer screening. One thing we noticed was that we heard a lot of different stories from our coordinators. We were struggling to recruit. 50,000 is the biggest randomized trial the VA has ever done of an intervention like this. And the previous largest was a shingle study, and that was relatively easy compared to this. No offense to anybody involved in the shingle study. But we heard people saying, nobody wants a colonoscopy here in Houston. Like, everybody wants a FIT. And we heard other places, nobody wants a FIT. Everybody wants a colonoscopy. So we looked at some of the data we had, and overall, looking at over 7,000 people declining to consent who were eligible, 25% of them said they wanted FOBT or FIT versus 20% saying colonoscopy. So patient preferences matter. And we saw regional differences. Note that in the Northeast, it was relatively evenly split between colonoscopy and FOBT, whereas in the West, there was a big preference for non-invasive screening. We don't have information on the people who declined in terms of age, gender, race, ethnicity, et cetera, so we can't comment on any of that. Now let's talk about the 50,000 randomized. We have nice diversity. We have 24% African American or Black. We have 1% Asian, 1% Asian, 1% American Indian or Alaska Native. I think we might have the largest study of screening colonoscopy of American Indians, Alaska Natives, but I don't know that for sure yet. We have about 12% are Hispanic or Latino. If we focus on the screening colonoscopy, we have 658 people performing these colonoscopies. There's about 17,000 colonoscopies. We have mostly gastroenterologists doing it, but some surgeons and others, and we don't have data on everyone. Obviously, we're making the endoscopist a study participant, and we cannot mandate that they tell us their age, their gender, their training, their specialty, et cetera. So we have some missing data. But they tend to be pretty experienced, 4,500 colonoscopies since training. And what you see here is that of about 17,000 colonoscopies where no cancers are found, and the reason that's an important thing to mention is that I'm not allowed to see any of the data on anybody with cancer. The study is ongoing. The data monitoring committee will not release any of that data for many years. So our sequel intubation rate, that is getting a complete exam to where the appendix is over 97%. That's excellent quality. The inadequate bowel preparation rate is under 8%. That's excellent. The benchmark is it should be less than 15%. We're at 8%. That's great news for the VA and for our veterans. So overall, over 91% of procedures were complete with adequate bowel prep. We found adenomas. Remember that adenoma detection rate I mentioned earlier? In 45.7%. Remember that Kaiser study where I talked about 25% is the benchmark, and the highest in Kaiser was 55%. Well, we did quite well. And we found advanced adenomas, which are large, are worrisome histology polyps in 9%, and we found the cess-ulcerated lesions in about 4%. Here's the adenoma detection rate across many of the sites in the confirmed study. And you can see that our best sites have adenoma detection rates over 60%. And the lowest was well over 30%. So overall, the quality was quite good. The red numbers are the adenoma detection rates. The other colors are for the advanced polyps and the serrated. I don't have time to go into it, but we have a lot of great data on the association between these various demographic factors and exposures like age, gender, race, ethnicity, BMI, smoking, alcohol, aspirin, et cetera. We took a lot of baseline data. And so we can spend years analyzing this, but we haven't had time to do that yet. If we do a back of the envelope calculation, and this is very back of the envelope, please do not do not take this too seriously, but the confirmed study is the one I just described. VA380 is another study that Dennis Ahnen was involved with. David Lieberman is the leader of that study. They did screening colonoscopy. They included people with family history that we excluded. So overall, their population was higher risk than ours. Yet we found 9% more patients had adenomas. Now, do we think that over 20 years, 9% more veterans developed adenomas, or is it the technology, better scopes, better technique, better bowel preps, et cetera? I think it's the latter. So we're going to look at that a little further. We also looked at complications of colonoscopy. We have over 17,000 colonoscopies. 3% had an adverse event of some type. These are mostly mild things. I'll touch on that in a minute. And 1.3% had a serious adverse event. Adverse events included things like blood per rectum, abdominal pain. Proctalgia is pain in the anal area. Other adverse events, several procedures were canceled due to nausea and vomiting. We had people who their bowel prep made them throw up so badly they didn't want to have a colonoscopy. They canceled their procedure, or severe cramping and bleeding post-procedure in one patient. When you look at serious events, most of the serious adverse events were not related to the procedure, but we did have 31 serious bleeding events, 31 cardiovascular events, and 5 perforations. So when looking at the details of those perforations, I don't think they were all truly what we call perforations. And we found that polypectomy, not surprisingly, was associated with serious adverse events. So overall, our rate of perforation is about 3 per 10,000 and bleeding 18 per 10,000. At the end of the day, we're going to look at colon cancer mortality, and we've got a committee that is doing adjudication of all the deaths to determine which are colon cancer deaths and which are non-colon cancer deaths. And we're going to get a graph, like either what you see on the left or the right. Either the two are the same or they're different. And I don't know which is going to be, and I don't know whether red is colonoscopy or red is spit. I'll tell you in a few years, it's going to take us till 2028 before we have the results of the study. It's 20 years from conception to graduation year. This study would not be possible without so many people shown on the next few slides. Note Dennis Ahnen under the executive committee. And my mentor, Don Provenzali, also passed away in the last year, unfortunately. We have many, many other investigators who I wish I had time to read their names, but I don't. So the takeaway points: colorectal cancer is the second leading cause of cancer death in America today, but it doesn't need to be. We have effective screening tests that are available and affordable. I didn't go into the cost effectiveness data, but it is cost effective. We have multiple proven screening options. Which test is best? The best is the one that gets done and done well. We need the results of the randomized trials. We'll get the Spanish study soon, the confirmed study in a few years. There's other studies from Europe that are underway. I think you should recommend the tier 2 options, colonoscopy or FIT, but don't get too fixated on one test. Patients should have options. And if you offer colonoscopy first and they don't do it, you should give them the option of FIT and vice versa, because adherence ultimately drives effectiveness. And if we do a good job with this, my hope is that we can fill T-Mobile Park with the 53,000 people whose lives we save every year. Thank you very much.
Thank you so much, Dr. Dominitz. That was an outstanding review of all the modalities we have to actually make an impact to decrease the burden of this disease. And thank you for being here at the VA. It's very, very special to host you. To kind of talk about some of the contributions that you reviewed and the contributions really specifically that VA investigators have made. We have a lot of folks tuning in that are sad to miss an in-person VA research day today, but what words would you might have to speak to that audience, and especially young investigators that are getting started in this field, about the areas that they could fill?
Thanks, Swati. You know, I think VA is an outstanding place for doing research. Not only do you have the ability to do research like any other investigator at a university or elsewhere in terms of applying for NIH funding or industry funding, but you also have the ability to apply for NIH funding, and you have access to VA data. And we have incredibly rich data sets. I mean, you know, the Charles Coffey study I mentioned with the colonoscopy and colon cancer mortality was done using administrative data from the VA. And you know, there are some gaps in our data, and you and I have talked a lot over the last few hours about the kinds of data I'd like to see the VA get on colonoscopy quality. We're trying to build infrastructure. I'm going to talk more about that a bit tomorrow. But still, there's a lot of data that can be analyzed, and it can be done relatively efficiently. And there's always more questions to ask. Things are always changing. I have to tell you, when I was a fellow, I saw the world of colon cancer screening as being crowded with all these giants like David Lieberman, like Dennis Ahnen. And I thought, there's no way I could possibly have a career in doing this. I mean, I can be, you know, a third-rate investigator at best. And what's interesting is that, first of all, these people, especially people like Dennis and David Lieberman, are very open and accepting to mentoring young investigators. And I would like to believe that I am as well. And, you know, I'm pulled in a lot of directions, but if I can help in any way, please don't hesitate to reach out to me. There's always new questions coming up, and some of them can be addressed relatively easily with VA data. I mean, I tell you, I've got dozens of questions that I want to answer. And I'm constantly emailing my colleagues like, hey, I got this idea. I'm the executive director of gastroenterology. Sounds impressive in a way, but it's not. I mean, it's a title, but we don't have a lot of resources. I'm like, let me write a letter of support for you to write a grant. You know, I want somebody to do this, and I'll give people ideas. And we've been successful. I mean, there's a few grants that are out there right now funded based on things that I said to someone, I really think we need to address this, or somebody came to me and I said, let's work together on getting this funded. And we partner on trying to get support from VA leadership, research leadership, HSR&D studies, query studies. So I think there's always opportunities. I think if you're interested in this field, don't be afraid of it being overcrowded. There's always new questions coming up. I mean, you know, it doesn't have to be just GI. I mean, COVID, who would have thought of that 3 years? I mean, some people did, I know, but tons of papers coming out about COVID. The VA was actually a leader on pandemic planning, as many of you know. And there, I can't guess how many thousands of papers have been published on COVID in the last 18 months. And, you know, my institution's got lots of funding on COVID projects. So I hope that answers your question. If not, let me know.
Yeah, thank you.
Let me ask you a quick question. You mentioned that sometimes the polyps are not completely removed. So what do you recommend to patients? And is there a way to do kind of rapid on-site evaluation? We sometimes do it in the Bronx Suite, you know, yep, you're in the lesion. Yep, we got cancer. you can stop biopsy? Is a way to look at the polyp and say, I got it, or we have to wait for a path report and then say we're going to go back at some interval and have it again?
It's a great question. So to repeat, in case the audience didn't hear it, the question is, essentially, can we do a rapid on-site evaluation to what's called ROSE, rapid on-site evaluation, to see if the lesion was completely removed if you got the diagnosis? And unfortunately, I think the answer is essentially no, not in GI. I mean, we're finding polyps, and as you saw, over 50% of patients in the confirmed study, 47% adenoma detection. We found many other polyps that were not adenomas. And it could be, one polyp, it could be a dozen polyps or more. Part of it, and Swati Patel is one of the leaders on polypectomy technique and assessing it. I'm going to mention this again tomorrow, that we're recommending using cold snare to remove polyps rather than biopsy forceps. And I have to admit, I was trained to use forceps on small polyps, and I'm converting my practice to using snare more and more, because we find that when you use a snare, you're more likely to get the whole polyp. We need to get better at that. And I don't think we have a good way of doing that. It's one of the biggest challenges for us. The adenoma detection rate is the best measure we have of predicting quality of colonoscopy, but I think it falls far short of the ideal. You could talk about how many adenomas did you find? Because if you find one adenoma and then spend 10 seconds pulling the scope back, your adenoma detection rate is going to be fine, but your protection of that patient from colon cancer is not. So we need to get better at that. I think AI may help us with that. Ideally, the AI would say, ding, 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 you've got the polyp that looks good, or, hold on, you haven't grabbed all of it and you're missing a piece. Once you take a polyp off, there's a whole bunch of swelling and blood, and it's really hard to see, depending on how you do it. So I think that's a challenge. It's the next frontier of quality measurement. I think it's hopefully in the next 5 to 10 years, but it is a challenge.
Do the pathologists comment on it or not?
The question is, do the pathologists comment on whether or not you completely remove the polyp? Kind of, it depends. If you're taking out a pedunculated polyp that has cancer in it, they may describe the cancer is, 1 millimeter away from the margin or however far it away is. And we have some rules about how far away from the margin is good enough to say it's complete resection. But often, we take out a big polyp and we suck it through the channel of the scope. And in that suction process, it fragments into 5 pieces. And then there's no way of knowing whether you got it. And if you biopsy a polyp, if you take it off piecemeal, there's no way for a pathologist to know that.
One of the questions that came through in the chat is about these 2-step screening modalities that we have. And can you talk about some of the efforts that the VA has been doing to try to improve completing the process of screening for a positive fit?
Yeah, I'll spend a little bit more time on that tomorrow, I hope. But a fit is only going to work if the positive patients get a colonoscopy. Same is true of CTC, Cologuard, et cetera. And as I mentioned, in the VA, the rates are lower than we'd like. It's more like 50%. Some of you may be familiar with the what's called the colon cancer screening surveillance reminder system. We have an average risk reminder, we have a colonoscopy due reminder, we have a gap reminder when somebody has a colonoscopy that asks what the follow-up plan is, and we have a fit positive reminder. So anybody who's fit positive has this alert on their screen that says fit positive, colonoscopy due. And as a clinician, you can go in and you can put a note that says, I'm ordering a colonoscopy, which is what we hope will happen for the vast majority of patients. Or you could say, I'm not ordering a colonoscopy because they're 90 years old and they have metastatic lung cancer, or they're 55 years old with metastatic lung cancer. So sometimes it's appropriate not to do that. I'll show a slide tomorrow where we looked at it, and about 1/3 of the time, unfortunately, the reason given for no colonoscopy do not seem appropriate. Like the patient is too old, but their age is 76 to 85, which I would say is not too old. Or they say they're too young and their age may be 46 or 49 because the guidelines said screen from 50 to 75. Now our guidelines say 45. I would still say you should offer a colonoscopy. There are people who are fit positive who don't need a colonoscopy, but the vast majority should be offered it and should undergo it. And I think part of it is that reminder, but part of it is we need to train ourselves to do a better job of educating patients about the importance of colonoscopy, because the risk of cancer is about 5%. But there's also barriers to colonoscopy, transportation issues, time off from work issues, getting a ride, all of that. And I think the VA has those issues perhaps more than Kaiser does, which may explain a lot of the differences, but I still think we need to do better. In the non-VA world, one of the challenges is the cost, because you're no longer doing a screening procedure. And I know groups like the GI societies are lobbying Congress to try to change it so that, you know, a screening fit is free, a screening colonoscopy is free unless you find a polyp, in which case it now has a charge, although they're working on eliminating that over the next 10 years. So there's work to be done for sure.
Great. Well, thank you so much for joining us at virtual VA Research Day this year, Dr. Dominitz. I did send the link out to your lecture tomorrow morning that will be at 7 a.m. Mountain Time. We hope everyone can tune in to hear about some of the challenges in screening, which I think dovetails on a lot of the questions that have come through this afternoon. So thank you everyone for tuning in. Thank you for your attention. Thank you for your time, Dr. Dominitz.
Thank you. It's been quite an honor to be here.